Okay, well thank you very much for taking time out of your busy day for this next half an hour. But I hope you'll agree it's for a really important topic, and it is a reminder to us all why infection prevention is so important. You will be aware we're doing quite a few of these sessions, either myself or Dr. Odom, or we might even do a double act, who knows, over the next sort of 2 weeks, I think it is. To raise awareness with everybody around infection prevention. And you might ask the reason, well, why are you doing it? We've been talking about infection prevention for long enough. The reality is that many people have kind of forgotten the dark days of infection prevention in this organisation when we were the third worst in the country for MRSA bacteraemias, that's bloodstream infections. Pop your hand up if you worked in this organisation in 2005. Maybe about half. Okay, so 50% of the people will not remember the bad days when the Department of Health came in, and really we were very embarrassed to be found wanting in our environment, in our practice, in our knowledge base, in our attitude about infection prevention. And a lot of hard work was put in to change the culture, change what we were doing on a regular basis, and the patients benefited. So you're going to see that through some of the slides. So let's kind of move on to the good news story of where we're at the moment. So the bloodstream infection, MRSA. Now you've all heard of MRSA. It was in the press. I can't remember if it was the Daily Mail or the Daily Mirror that spearheaded this in the public. They're the ones that said you have to take this seriously and you have to do something about it. Interestingly, healthcare didn't take it that seriously. They just said, oh, there's nothing we can do about it. So it's quite embarrassing for us as a health service generally to have to be bullied really into doing something about our poor infection prevention practices nationally. But what we did do was, when the Department of Health came in, we opened up our minds and we listened. We didn't defend, we didn't get all antsy and say, well, it's just a ridiculous target. We stopped, we listened, and we acted. And that shows some emotional intelligence as an organisation, as a learning organisation, that we wanted to improve, and indeed we did improve. So you can see the highest blue bar, 82 bacteremias in 1 year. That was in 05-06. And then you started to see the numbers coming down with a dramatic drop. And it stayed pretty low ever since. We have been over 3 years without a bacteremia. Some of you will remember we used to count up every day, it's another day, and everybody was saying, we don't want to be the ones that have the bacteremia. But you know what, we had a discussion at the board and said it will happen. We will have a bacteremia, and how we respond to that is really important in terms of leadership. It isn't about leaping up and down and being angry and blaming people. It's about saying we've done really, really well to go 3 years. But you can see from the note, the bullet point at the side, the first time in Wolverhampton history we've had no MRSA bacteremia in 15-16. So that's across, not just in the acute setting, the community setting, it's across the whole city, the health economy of Wolverhampton. And as we sit here today, and I'm not superstitious, but I'm finding wood to touch, we've gone more than 500 days without a bacteremia. So fantastic, well done. And how we've done that is good practice, our knowledge, being consistent about our practice, and our hand hygiene. We also looked at MSSAs, so these are the infections that are sensitive, so the methicillin sensitive bacteria. And you can see from the blue graph, the blue blocks rather, it's come down rather nicely again as well. These are a little bit more difficult because most of us will have Staph aureus on our skin. So what we have to be vigilant is when we're starting to put things into the body, like cannulas, for example, that there's a potential portal for infection there. So that's another good news story. A lot of organisations don't even measure this particular infection. And then we moved on to look at device-related bacteremias, which I've kind of alluded to. When we put something in a patient, a foreign body, whether that be a cannula, it could be a peg feed, it could be a drain, Something where infection could get in, it's always a higher risk. So we've been monitoring this for some time now. And again, you can see the numbers, the line is coming down, not as dramatically, but the red line, which are deemed to be the avoidable DRHABs, as we call it, they are coming down. And we do a root cause analysis to understand why the patient had a bacteremia. The best way of preventing a DRHAB, any ideas? Don't put it in the beginning. So our focus is only put things in patients if it's really necessary, and only keep them in there as long as required. As soon as they're not needed, take them out. Don't keep a cannula in a patient just in case, because that just in case also can be the risk of infection, being a patient being exposed to that. So that's a good news story, and you think, well, that's it, we've cracked it, haven't we? Well, maybe we have in some of the infections, we're on the right road, but there are new challenges for us, and that's really why we're getting everybody together to say we need everybody to understand those challenges and what we can do about them as an organisation, you can do about them in your team, in your profession, and what you can do individually. So C. difficile, Clostridium difficile, has been around for a long time, and when we started our journey we saw a big drop. Now C. difficile is an infection, and patients who have this often, not always, have diarrhoea. Some of you will be very well aware of this in the audience. It is a particularly horrible infection. We had one lady who had had bowel cancer and had had the subsequent treatment and some surgery and some chemo. I think she had radiotherapy as well, maybe not. But she'd had a rough time with it. Subsequently, she developed C. difficile, and she said, give me bowel cancer any day. That's much better than having C. diff. It makes you feel so terrible and so weak, having diarrhoea, and really our mortality rate back in 2005-06 was 40%. So 40% of patients with C. diff would have died. We saw that drop rapidly, and the numbers dropped. And what we also saw was that patients who had C. diff weren't actually as clinically sick as they had been previously. We're now seeing a bit of a change again in this particular infection, where patients now are starting to get more clinically unwell with C. diff again, and the numbers are going up. We are not controlling C. difficile at all, and I'll talk a little bit more about that in a while. MRSA acquisition, well, you might say, well, you've just said we've done really well on MRSA. Well, that's the bloodstream infection. Acquisition is when the MRSA is on your skin and it's somehow moving from patient to patient. And we know it does that because we screen patients when they come into hospital, and patients who come in as negative for MRSA on their skin, at some point later in their stay, they're becoming positive. So somehow they're picking up that organism on their skin. If they're doing that and then they have cannulas, there's more of a risk of them then getting a bloodborne infection. We know nationally, not just here, that antibiotics have been lifesavers for many, many years now. But actually, we're kind of running out of some of the new antibiotics, and patients are becoming more and more resistant to antibiotics, or their infections are, I should say. So that's a real challenge, to ensure that we use antibiotics appropriately for the right patients, for the right reason, and for the right duration. No more and no less. And so some good housekeeping around that is a challenge for us. And that affects not just people in this room who prescribe antibiotics, but those who give antibiotics as well. Don't carry on giving antibiotics for 10, 14, 21, 28 days, when actually it should have been a 5-day course or 7-day course, whatever the prescription is. And we're getting some emerging infections, and I'll share one of those with you in a little while, and why it's such a challenge for us. So here's a graph about C. difficile. Sadly, we have breached. I'm not going to say it's a target, because that sounds as if almost we have to reach it. It's a limit that's set for us. You can argue whether it's a rational limit or not, but year on year we are breaching that limit. And this year doesn't look any better, to be honest with you. We have some good months, but by and large we're always going over the limit. And the sad news is that of those that we have to do a root cause analysis with the commissioners to decide if they are avoidable or not. And one of the reasons that they decided that they may be avoidable is if people haven't undertaken their mandatory training to demonstrate that they understand the appropriate use of antibiotics, the prescribing and use of antibiotics. We have had 8 incidents where it would appear that we have transmitted the C. difficile infection to a patient through some poor practice. So that is really quite concerning it should be concerning for all of us, but certainly we look at these RCAs very, very carefully to understand how it's happening. The MRSA acquisitions we talked about, the graph shows you that we've seen an increase in acquisitions from 13-14. We've had outbreaks where we've had colonisation of MRSA, and again we undertake root cause analyses to understand, what's happening, what's the pattern, how is this being transmitted in an area, in a clinical area for us. As of last November, it doesn't look as if we're improving on our acquisition rate. So we're going to have to think about what do we need to do differently to be more vigilant about this MRSA moving from patient to patient, patient to staff, staff to staff, staff to patient, whatever it might be. We talked about emerging infections, and CPE is one of those infections. Now, why we are so concerned about this is that we haven't got the opportunity to decolonise a patient when they're swabbed and found to be positive for CPE. Now we can do that with MRSA, and many of you know that's what you do. When you swab and it comes back positive, we decolonise the patients. We haven't got that opportunity with this group of patients, and we are seeing a rise in the number. Now with CPE at the moment, who knows what's around the corner, with CPE, once you have it on your skin, the likelihood is you're going to have it forever. So it's really important when patients are admitted that we undertake the proper screening process so we know where these patients are and how best we can care for them. That will usually be in a side ward, of course, with isolation practices put into place. But we do have an opportunity to minimise the threat from this infection, from this organism, I should say. Because once it's out there, there's no getting it back. We talk about, can of worms, you can't get the worms back in the can. It's the same with CPE. And one of the, I think it's my next slide, no it's not, I'll come back to it, but one of the organisations in Wigan, they had the same sort of number of CPE patients, positive patients, that we currently do in our organisation. Between 3 and 5 years on, their numbers have spiralled out of control, and they're spending between £2 and £3 million a year on these patients through extended length of stay. So this is not only bad for patients, obviously, but it's bad for us as an organisation. Extended length of stay means we have beds taken up by patients, and so our acute patients can't get in. In terms of antimicrobial resistance, I've sort of alluded to, short course of antibiotics, make sure you stop them when they should be stopped. If you change antibiotics, stop the one that you've started. And that's about prescribing awareness, as well as the nurses who are giving the antibiotics also being aware and not just saying, oh yeah, 4 hourly, and keep giving them day after day after day. We know we have the sticker that was designed to help people focus on how long is this antibiotic to be for, the frequency, when's it going to stop, etc. We've also started a project across the whole health economy with public health, the CCG, that's a local authority as well, and ourselves, to raise awareness about the use of antibiotics, because we know that in the public domain, sometimes public think antibiotics are just always going to be there and they're always the cure. How many times do you hear that people go to the GP with a cold, or they take the child with a cold and demand antibiotics? And the GP says, but it's a virus. Antibiotics aren't going to work, but they demand the antibiotics. And I feel quite sorry for GPs, because it must be very difficult when, you know, anxious parents or anxious patients are in front of them. And the GPs have reported, in the end, we just give up and we give them a prescription for an antibiotic. They will not go away without. And they know it's not the right thing to do. So we really need to get the public as aware about antibiotics as they were about MRSA, and not ask for them. And we're also going to be working with schools, because we think if we can get into the younger generations, they will start to influence parents as well. So not so many antibiotics will be prescribed. So, okay, you're all here now, hopefully, you know, ears open. There are various things that we would like you to do. Obviously, learn from what you've heard today and share with as many people as you can. Think about your practice. We would like you all to make sure that you are compliant with your mandatory training. Now, there's some people in the audience, and certainly myself, we're on the infection prevention group every month, and every month we have a conversation around mandatory training and why won't people undertake their mandatory training. Now, before anybody jumps out of the audience, yes, I know there are problems with the database that we have. It isn't the best. We know that. It doesn't have the ability to email you individually to say you need to do your hand hygiene training within the next 8 weeks. It isn't that sophisticated at the moment. But that's one of the reasons we haven't set it at 100%, to allow for that error rate. The reality is many people just don't do it. They're amber for 8 weeks, they don't do it. They go red, they don't do it. They have a letter, they have a phone call, they don't do it. And that's really hard to sit in front of our non-executive, our patient representative, and say, people just aren't doing it. It is a reasonable management request. It's part of our contract that we will adhere to our policies. So please be aware and take responsibility for your own mandatory training. Don't wait to be poked, don't wait to be told, to get an email. You know, have a reasonable idea about when you might be needing to do it. We know that if we can isolate our C. difficile patients within 2 hours of symptoms starting, we reduce the risk of then spreading the infection through the spores of C. diff. That also means we get them isolated from toilet facilities as well, which would be a real source of potential infection for other patients. The antibiotic prescribing sticker, please use it every time. We do audits on it now. I wouldn't say poor compliance, that would be wrong, but we're always some way short of where we should be for use of antibiotic stickers. I've talked about stop dates for antibiotics. Environmental audits. Now, the Trust Development Authority came in over a year ago now. They told us they were coming in to do an audit around our environment, our cleanliness, our infection prevention. They asked us where we wanted them to visit, and we gave them various areas in agreement with those areas. And they came in, they found us wanting badly. That was embarrassing. It was embarrassing. It's like, you know, your relatives coming for Sunday lunch, you know they're coming, you know what the meal is, and you haven't got any food in, and you haven't cleaned, and you know, you're still in your pyjamas or whatever. It was very embarrassing, and it was very, for me personally, I was very hurt when they said, we always used to send people to Wolverhampton for infection prevention to say, go there and see how it's done, and we can't do that anymore. That was very hurtful because we'd had such a good national reputation. They gave us 5 weeks and said, we'll come back. We'll re-inspect the same areas. We didn't do much better. Now, what does that tell us about our own standards, our own ownership of our areas? Third time lucky, they came back, and thank goodness we've got our act together. But of course my worry is we don't need the TDA to come in every time and tell us things aren't right. We should have that ownership ourselves. We should take pride in our environments, making sure they're clean, they're tidy, not cluttered, etc, etc. We monitor on a monthly basis the use of high-risk antibiotics through our infection prevention group. So we know exactly for both divisions how they're being used, where there arises, why there arises, whether they've been prescribed in conjunction with the microbiologists or not. Many of you will know through Safe Hands, so the badges that we have. We're working on how we can monitor and measure hand hygiene compliance when you have interacted with a patient. I can't say it's in its early days, it's not quite early, but it's certainly not in the final stages. The data isn't robust enough at the moment to use rigorously to let you know as a ward, a department, a profession, individually, what your hand hygiene index is. And that means, you know, do you decontaminate your hands when you should decontaminate them when you're interacting with patients. We need to see people using protective equipment appropriately, so that's not overusing it when not needed, but certainly using it when patients particularly are in isolation. And I've alluded to this before, if somebody has a catheter in or a cannula that no longer needs it, go and have a word with somebody and see if we can take it out. Always think of it as a source of potential infection. So the sooner you take it out, the less chance is that a patient will develop an infection. We are so concerned about infection prevention, we keep it on our risk register in the organisation, so the board do see it regularly, at least monthly. Well, one of the sub-board committees see it monthly, the board see it bi-monthly. And I'm sure many of your areas have got infection prevention on their risk register as well. And I think I always try to put it in the context of, if I came into hospital or my relatives came into hospital, what would I want for them? And I think everybody in this room would want the best for their loved ones. And therefore, what we should want for our patients should be no less. And it's what we're here for. We care for our patients. We pride ourselves in safety. So I think we can definitely up our game a bit and be more consistent about our practice. I was on a ward last week and was really disappointed to see somebody go to a patient with a long jacket on, interact with the patient physically. They weren't bare below the elbow, they did have a wristwatch on, and of course somebody had to intervene. Now, back in 2005-06, we created a culture where anybody can intervene with anybody who isn't undertaking hand hygiene, for example. And this isn't about being bossy and nasty. We all forget, we're human. And if I forget, I would really like somebody to remind me and say, oh gosh, Cheryl, I think you've forgotten to gel your hands. You know, have you run out of gel, or, you know, whatever the case may be. I was really proud when I heard that we'd had one of our housekeepers politely and appropriately challenge one of our senior consultants to say, excuse me, you haven't gelled your hands. And the consultant responded very appropriately, wasn't rude, there was no offence taken on either side, and actually there's an opportunity to keep the patient safer. So I want us to create that culture again. Why wouldn't you want to keep each other safe? If we were crossing the road now, maybe, let me use your family, I'll use your colleague, but you know, if you were crossing the road with your loved one and you saw them stepping out and a car was coming, would you just step back and watch them get run over? Well, you wouldn't, would you? It's no good saying, well, I'm okay, I haven't stepped off the pavement. You wouldn't. You would say, oh, I'm going to be careful. So let's create that culture that we're trying to keep each other safe so we keep the patient safe. Okay, so it does say in summary, we know good infection prevention practice results in decreased mortality, so that's decreased death rates for our patients. It's better patient experience. You know, I think many of our patients come in very poorly, to then give them another infection to cope with. That's pretty grim, I would suggest. So the whole experience can be improved by better infection practice. From an efficiency, we know we reduce length of stay. Back in 2005, we closed wards through better infection prevention practice. It means you have more beds available. Anybody in here from ED? No, okay. You know, if those patients come into ED, they can get them in, they can get them out into the beds when they're available, when we're not having people extending their length of stay because of an infection that they've developed. Reduce the dependency, so patients can come in with one condition and they can look after themselves. They then get an infection, become very dependent. That's much harder work for you guys to look after that patient. And I've alluded to this before, you know, it sustains the trust's reputation. Who wouldn't want to work in a trust that has a fantastic reputation for infection prevention? I think we all would. And there might be people in the audience thinking, do you know what, Cheryl, you've been talking now for 27 minutes, but actually I'm not a nurse, I'm not a doctor, I'm not a physio, I'm not clinical, what's it to do with me? Well, what it's to do with you is everybody has a responsibility around infection prevention practice. And the best way that anyone in this room can prevent infection is through proper hand hygiene. Okay, washing your hands or gelling your hands, if that's appropriate, I'll come back to that, but gelling your hands when appropriate, after you've interacted with a patient or the patient's equipment, environment, etc. So it's good discipline to have, good discipline. I said I'd come back to it because we gel our hands most of the time, but we know that in cases like norovirus, which is the winter vomiting bug, and C. difficile, gel will have little impact. It has to be soap and water. So good thorough washing hands with soap and water. And of course, everything I'm saying now around hand hygiene can be translated back into your homes as well for good infection prevention practice in your own homes. Okay, so a couple of things to finish off with. 11th to the 15th of July, there's a hand hygiene torch tour across the world. It's a little bit like the Olympic torch, isn't it? I saw it in Malta, and it's travelling around, and it's coming to Wolverhampton when?
Next week.
Next week, so you might see it.
It's here at the moment, but the campaign's next week.
So the campaign's next week, so we've got it. And I think some people might have been approached this week to speak into a camera and say something, one sentence about infection prevention. I did mine a couple of days ago. We're having a refresh of our posters because we know we go blind. If you see the same thing time after time after time, you just don't notice it. So refreshing our posters to remind people about infection prevention. And there's a public facing campaign. This is in addition to what we're doing about antibiotics, but it is about the whole infection prevention in society, not just in the acute setting. So if you want to get involved, let us know. And the final thing, and I have remembered, this is a fantastic opportunity for me to just remind people, I know it's summer, and maybe you're thinking, what are you thinking about this now, Cheryl? But start thinking about the flu vaccination. It's one of the best ways you can protect yourself and your families through having the flu vaccination through this organisation, and we will be ordering it and starting in September, so it's not too far away, is it? It's still sort of summer months in our head. So I would really love it if more of us this year had the vaccination than last year, and let's beat our record of flu vaccination.